So as you know that the importance of fluid resuscitation, uh, choice of fluid resuscitation also, and amount of fluid resuscitation also I've discussed. But the fluid resuscitation should be guided by the clinical response. It should not be endless. Like for if you started 500 ml and then you keep giving 500 ml for hours together, that may cause fluid overload. So you have to understand that also, because there will, especially in patients with the sepsis, there may be capillary leak, patients with the urinary tract infection, pneumonia, they may have a vasodilatation. And if you keep giving excess of these crystalloids, okay, these fluids may go into the interstitium and can cause interstitial edema and will lead to a third spacing, and patient will be bloated next time. So that's why fluid resuscitation has to be guided by the clinical response. You can use fluid responsive measures, CBP, and lactate levels and bicarbonate levels also. Basic excess management measurement, normalization of the base excess also can give you enough idea about the adequacy of the fluid resuscitation. So let us come to the insulin therapy. As we know that insulin is also one of the cornerstone of the management of diabetes as against IV fluids. The insulin therapy should be started simultaneously along with the fluid resuscitation. And the main advantage of insulin is it reduces the glucose levels, and it also reduces the glucose production by the liver, and it also reduces the ketogenesis, because ketogenesis happens because of lipolysis and the excess of glucagon secretion, which break down ketones or lipids or fats and produce ketones. Okay, excess of ketogenesis can be prevented, because when the insulin levels are low, there will be excess of glucagon. Glucagon is also a counter-regulatory hormone for insulin, which is similar to catecholamines, which will try to antagonize insulin in most of the occasions. Okay, so that's why we need to understand that the insulin therapy is just to reduce the sugar levels, and it will also probably reduce the production of the glucose by the liver. And insulin will also help utilization of the ketones, the excess ketones that are produced. That ketones can be broken down again and can be broken down to lipids or fat again, and then the glucose, excess glucose production can be controlled with insulin. So as we know that when we start insulin, the electrolyte that we need to monitor is potassium, because insulin will shift the potassium intracellularly, and patient will have factitiously low potassium levels and will have arrhythmogenic potential. And sometimes if you're given excess insulin, it may cause life-threatening hypokalemia and can cause bradycardia or can cause arrest also. So that's why as far as insulin therapy is concerned, we have to be very cautious. The initial insulin should be bolus of 0.1 unit per kg. So like if I'm a 50 kg patient, the initial bolus will be 5 unit IV bolus upfront you can give. If it is 60 kilo, 6 units per kg. If it is 80 kilos, you can give 8 unit bolus immediately. Okay, and then we have to start a continuous infusion at 0.1 unit per kg per hour. Okay, so if you are given 5 unit bolus, then start 5 unit per hour infusion. And our goal is to reduce the glucose by 50 to 70 milligram per deciliter per hour. And the titration should be according to this much drop only acceptable. If the glucose levels are dropped by more than 100 milligram per deciliter, we may have to reduce the insulin infusion by half. If it is going at 5 units per hour, you may have to come down to 2.5 units of insulin per hour, and that will help you to reduce sugar levels. If there is excess of glucose of around 500, so it may take around 10 hours for you or more than that. Okay, so suppose if the sugars are 400, Okay, and you have to reduce the sugars by 50 to 70 milligrams per deciliter. You may have to uh, get the sugars to normal, means up to 200 to 250 milligram per deciliter by around 8 hours. Generally what happens, we ask sister to give insulin. After insulin and patient sugar which was around 500, and suddenly it comes back to normal around 120 or 150, and we become happy that sugars are controlled. That's not all. We should feel like, it can have its consequences, because sudden drop in the sugar levels can cause shifts in the brain, fluid shifts in the brain, and can cause cerebral edema, and patients can have uh, seizures also. So to prevent these sudden electrolyte and fluid shifts, we need to cautiously reduce sugars by 50 to 70 milligram per deciliter. And once we get the sugars up to 200 to 250, we should start replacing, glucose, and then glucose with insulin drip should be given. And that will help the glucose utilization by the tissues. The insulin not only reduces the sugar, but it also helps the tissues to utilize the glucose in a state of decay, because of loss of or absence of insulin, or reduction in the levels of the insulin. The tissues are not able to utilize this glucose. So in the bargain, by giving insulin, you are allowing the tissues to utilize glucose, and that's how you will have to start replacing glucose once you have brought down the glucose substantially to a normal levels of around 200 to 250. Okay, so once we bring the glucose down, we should also assess whether the glucose levels are, which are normalized, is a true success as far as the insulin therapy is concerned. So insulin therapy is guided by two ways. One is measurement of ketone levels, and second is measurement of osmolar gap or anion gap. We may have to measure anion gap on ABG. Okay, so generally we measure ketones. The ketone strips are available, or we can send the blood for ketone levels, the blood for ketone levels in the laboratory. So, but ketone measurement is little factitious, and sometimes it may be erroneous. The ketones are, there are three types of ketones produced in the body. One is acetoacetate, second is beta hydroxybutyrate, and the third is acetone. So initially, whenever there is high ketone levels, so initial ketones are either acetoacetate or beta hydroxybutyrate. So these then get converted into ketones or acetone. And then this acetone, which is measured by the Rothras test, which you do with the strips or, with the laboratory, this Rothras test can detect either acetone or acetoacetate, but it doesn't detect beta hydroxybutyrate. So in the process of your resuscitation and insulin therapy, you will see that the sugar levels have got normalized, but actually the sugar levels are not normalized, because the ketones are not normalized yet. Unless the ketones are normalized, you can't consider it as adequacy of the resuscitation, because this beta hydroxybutyrate is not detected by the Rothras test. So even if the ketones are negative or acetoacetate are negative, the patients may have positive beta hydroxybutyrate, which is not detected by Rothras. And after sometimes you do a ketone test and it will come positive, because that beta hydroxybutyrate is converted into acetoacetate and acetone. So that's why the measurement of ketones has become less popular nowadays. So that's why, to have a correct understanding of adequacy of resuscitation or insulin therapy or fluid therapy, we need to measure the anion gap. Okay, in ABG, you can calculate anion gap with the help of sodium, potassium, bicarbs, and chlorides. Normal anion gap is 8 to 12. So in the process of a resuscitation, if the anion gap is not closing or it is not getting normalized, it means that your resuscitation is still not adequate. The sugars are still not under control. The ketones are also not controlled. Later on, the patient again may go into decay. So the closing of normal anion gap is the solution, and that is how you titrate your insulin therapy and fluid therapy. What do you avoid? So as far as fluid therapy is concerned, you should try to avoid hypoglycemia, because overzealous insulin and overzealous fluid correction can lead to hypoglycemia, which may be very detrimental, and we may have to give the dextrose supplementation in this situation. And then we also need to keep giving orally to the patients also. Once the blood sugar is 200, as I already discussed, we should start giving dextrose. Okay, 5% dextrose or half strength normal saline, any of these is quite useful. But at the same time, you should also make sure that insulin is added. Glucose insulin drip can help you help the tissues to utilize glucose, and at the same time the glucose levels will also be controlled. What about ketoacidosis? We know that, whenever there is lipolysis, there is increased free fatty acids, which gets converted into ketones. And we have already discussed about three types of ketones: state, beta hydroxybutyrate, and acetone. And because of the accumulation of these acetones, there is acidosis, and in ABG you will see the pH is dropped down. So that's why we need to measure the anion gap, and normalization of the anion gap is the ultimate end result of normalization of ketoacidosis. But at the same time, we should also take into consideration the different types of ketoacidosis. The ketoacidosis may be due to starvation. If the patient has had not eaten for a long time, they may have starvation ketosis, and the ketones may be factitiously elevated. It may not be because of hyperglycemia only alone. Or alcoholic ketoacidosis also can present similarly. So in this situation, you will have to correct it with the fluids, and starvation has to be corrected gradually with glucose and phosphate supplementation to avoid refeeding syndrome. So these are the tests that we have to do it. Okay, serum and urine, either of these tests can be done to detect ketones, but serum ketone levels will be more useful and more promising to tell you about the status of the diabetic ketoacidosis. So in a nitroprusside reaction, which converts amino acids to acetone, theoretically it is possible to have ketoacidosis from even if the blood glucose tests are negative. So that's why we may have to add hydrogen peroxide sometimes to urine to get the better results and to detect ketones more efficiently. So whenever possible, serum ketones should be done. Urine ketone, if you are doing urine ketone, you may have to use hydrogen peroxide to detect the ketones. And then even if the ketones are negative, then sometimes in decay the ketones are negative, and you may get fooled by that normal or negative ketone levels that the patient doesn't have decay. But you have to look at the anion gap. If the anion gap is very high, that tells you that the patient is in decay, and you have to keep treating these patients with the fluids and insulin therapy. So normal anion gap is measured as sodium minus chloride plus bicarb. Normally it should be less than 12, and if it is more than 20, we call it as significantly elevated anion gap, and you have to treat, and it may be due to beta hydroxybutyrate or amino acids. The high decay, the cause of high ketones in decay is because of this. And then we have to look at the differential diagnosis also. If there is high anion gap metabolic acidosis, that can also be due to some other causes like lactic acidosis, aspirin, methanol, ethylene glycol, and even in patients with the chronic kidney disease, they can also manifest with high anion gap metabolic acidosis. So we have to consider these as confounding factors and these as a differential diagnosis. Whenever the patient is present with decay with high anion gap, we have to rule out these possibilities. And if these are the possibilities, we may have to treat lactic acidosis or these poisoning like aspirin, methanol, or glycol poisoning. And if the patient is CKD, that patient has to be dialyzed. So the institution of the therapy will differ if there are coexisting factors that are there along with the high in India metabolic acidosis. As we know that sodium is the most common electrolyte which is affected. Sodium and potassium both are affected, and the sodium levels have a direct impact as far as the hyperglycemia is concerned. And I have already told you, with every 100 milligram of rise in sugar levels, there will be drop in sodium levels by 2 milliequivalent. And then the secondary effects of osmotic diuresis can also lead to, if there initially there will be loss of, there will be hyponatremia, but when there is excessive osmotic diuresis, okay, which will lead to loss of more of a free water, then subsequently patient may have hyponatremia. So initial feature may be hyponatremia, but in extreme decay, extreme dehydrated state, the patient may present with hypernatremia. So any patient with the DKA having hypernatremia is an alarming sign, and that tells you that the extreme dehydration status of the patient, and it has to be treated with fluid resuscitation as rapidly as possible. Okay, some patients with the hyperlipidemia may have a coexisting presence, and that may also lead to pseudo hyponatremia. But hyperlipidemia is quite less often seen. It may happen with parenteral nutrition or propofol infusion, where patients may have factitiously low sodium levels along with DK, so it has to be corrected accordingly. So as far as potassium deficits are concerned, these patients will, due to osmotic diuresis and ketone excretion, and these patients will also, DK patients will also have vomiting, and some patients may also have loose motions. So there will be a loss of potassium due to excessive vomiting or due to GI losses. Okay, so that's why these patients have most common deficiency as potassium deficiency. And then we need to consider why this potassium is affected. It can be either due to hyperosmolarity or insulin deficiency or due to acidosis. It has to be treated, and potassium repletion is very, very important, especially in DK. So your target should be to bring potassium up to 4 to 4.5 milliequivalent per liter, and it has to be supplemented accordingly. If the potassium levels are less than 5, you have to start correcting potassium. If potassium is normal, we need to give 20 to 30 milliequivalents per liter of potassium in IV fluids. Okay, but if the potassium is low, we need to have more aggressive potassium correction, because these patients may have hypokalemia even with seemingly normal volume status sometimes. But if the potassium is low, you need to have aggressive potassium correction with potassium insulin drips. Okay, and potassium insulin drips can be given rapidly, maybe over 2 hours or 3 hours. Okay, so apart from sodium and potassium, we need to monitor phosphate levels also, because these patients will not be eating, drinking well, they will have starvation. So their body have a depletion of phosphate, especially with chronic decay or chronic diabetes mellitus. They will have low phosphate levels. Initially, the levels may be low, but as the fluid resuscitation goes on, because of excessive dilution, the phosphate levels may also drop. Decay can also be seen in patients with the pancreatitis. As you know, as I've already told you, pancreatitis can also be one of the trigger or a precipitating factor for decay. Decay, most of the times, 80% of the times, it will be precipitated by some precipitating factors. Infections are the commonest cause of precipitation of decay, either urinary tract infection or pneumonia or pancreatitis or any kind of sepsis that can lead to precipitation of decay. So whenever patient presents with decay, we should always have a thought process that this patient may have infection as a precipitating factor, and we should screen his CBC and see the WBC counts are elevated, their CRP levels will be elevated, and procalcitonin levels will also be elevated. So we need to treat these infections. Okay, pancreatitis are mostly non-inflammatory, non-infective, but it has severe inflammatory process that can cause decay because of the excessive systemic inflammatory reaction. There will be excess catecholamines, and then these excess catecholamines will cause inhibition of the insulin, and these patients may have precipitation of diabetic ketoacidosis. Okay, in patients with the hyperlipidemia, triglycerides, or these patients, the triglyceride levels also may be high because of excessive lipolysis in this patient. So how do we treat phosphate deficiency? So most patients who have phosphate deficiency, we need to have a symptomatic treatment. The most of the treatment will try to, once the insulin therapy is ongoing, the phosphate levels also go inside the cells. Okay, once the acidosis resolve, okay, there will be shift of phosphate inside the cell. So during the resuscitation phase and resolution phase, you will see this phosphate deficiency more often. So initially there may not be phosphate deficiency, but because of insulin supportive therapy and fluid resuscitation, the phosphate levels go inside the cell intracellularly and cause hypophosphatemia. So usually most of these patients are asymptomatic and they don't need the treatment. But if the patient has cardiac dysfunction, or patients have hemolytic anemia or respiratory depression, then phosphate correction may be required in these patients, especially 20 to 30 milliequivalents per liter of potassium phosphates can be added to the IV fluids, which is resuscitation fluid. How about bicarbonate therapy? There is a lot of controversy pertaining to the bicarbonate therapy in patients with severe metabolic acidosis, with diabetic ketoacidosis. There are small randomized controlled trials which are not shown improved management with the bicarbonate therapy. Instead, bicarbonate supplementation may be harmful in patients with the diabetic ketoacidosis, because the bicarbonate therapy will shift the oxygen dissociation curve to the left side, and 2,3 diphosphoglycerates will not be able to extract oxygen from hemoglobin and will not be able to deliver it to the tissues. So remember, bicarb correction will be harmful in patients with the decay. Exceptional cases, maybe when the pH is less than 6.9 and you have a desperate measure to correct acidosis transiently or momentarily for some time as a life-saving measure, then only bicarbonate therapy can be instituted. But routine bicarbonate therapy will be more harmful and will cause more anaerobic metabolism, more tissue hypoxemia. So that's why bicarbonate therapy should not be instituted. Even if it is given, bicarbonate therapy may lead to more carbon dioxide levels elevation, and then that may also lead to cerebral edema, and that will be more dangerous. So bicarbonate therapy may cause hepatic ketogenesis. It may cause metabolic alkalosis, which is harmful, especially when the patient has severe metabolic acidosis. So if at all we have to give bicarb, especially when the pH is 6.9 to 7.1, 50 to 100 milliequivalents of soda bicarb, 1 to 2 ampules over 2 hours can be given slowly. Okay. And how will you assess the resolution of decay? Once the decay is getting normalized, or the sugars are in their normal range of 200 to 50, you can start regular diet to the patient and switch over from IV insulin to subcutaneous insulin. In severe dehydration state, why subcutaneous insulin is not recommended? Because the absorption of the insulin from the tissues, which is hypoperfused, will be very negligible. So that's why initially, when the patient is present with the decay, the insulin correction is IV. But once the resuscitation is adequate, that IV insulin therapy can be switched over to subcutaneous insulin therapy, and that is especially when the patient has started eating orally. If the patient is eating orally, it means the patient has sense of well-being, the organ hypoperfusion is got corrected, and that is how you start subcutaneous insulin. So these are the causes of decays. I've already discussed: infections, pneumonia, gastroenteritis, UTI, pancreatitis. Even myocardial infarction patients can present with decay due to excess catecholamine levels, which may have a counter-regulatory effect on the insulin and can cause insulin resistance, and patients may have elevated sugar levels. Even patients with the stroke or trauma excess of alcohol or drugs or medications can also cause decay. Missed insulin and poor compliance is also one of the cause of decay. As far as the mortality is concerned, the mortality is higher in patients with elderly population around age of more than 65 years. You see, the mortality with the decay is very, very high. Whereas the mortality, is less with the young population because probably they can tolerate well. And with the diabetes, long-standing diabetes, the autonomic, imbalance sets in. The organs get affected one after the other. So patients with the elderly population have high mortality because of the organ affection. Okay, the heart, liver, kidney, all are affected, and the efficiency of the organs have also got below 100%. So they're not able to contribute much, and they may get decompensated rapidly. If the patient has myocardial involvement or coronary involvement, they will have low cardiac output, and they may get deteriorated with excessive fluid resuscitation. So that's why we'll have to have a cautious call on fluid therapy, insulin therapy, electrolyte correction like sodium and potassium correction, phosphate correction has to be very judicious, and close watch and continuous monitoring of these patients is very, very important. And mortality in decay is primarily due to precipitating factors. Precipitating factors like infections, decay, myocardial infarction, and elderly population. The patients with the coma or hypotension, which causes severe hypoperfusion of the organs, can be the cause of mortality. As far as the complications of decay are concerned, it can cause cerebral edema. Worsening of mental status is seen in 12 to 24 hours after starting the treatment. 0.5 to 1% of the cases are seen in children. Mortality is 20 to 25% with decay. And these complications can be reduced by prompt replacement of fluid deficit and correction of sodium, which will correct hyperosmolar state, and adding dextrose to the fluid resuscitation when the resuscitation is adequate. But also make sure that these patients have non-cardiogenic pulmonary edema. Excess fluid resuscitation can cause non-cardiogenic pulmonary edema. As far as hyperosmolar non-ketotic coma is concerned, the incidence is less than 1%. Most of the times you will see diabetic ketoacidosis as a precipitating factor for hyperglycemic emergencies. Hyperosmolar non-ketotic coma is common with type 2 diabetes mellitus, especially in patients with non-compliance to the oral hypoglycemic drugs. And the mortality also varies depending upon the presentation, how soon or how late the patient presents. The mortality can be variable, to the tune of 10 to 50%. And most often, hyperosmolar non-ketotic coma is also precipitated by precipitating factors like infections, sepsis, pancreatitis, trauma, and so on and so forth. So the causes, the factors of precipitating, HHH is similar to the decay. The only difference is decay is more common with more insulin deficiency, whereas HHS is more common in elderly population. Decay is more common in younger population. And then the precipitating factors are very high. Honk is, the incidence is less compared to decay. So as we see, HHS, honk, hyperosmolar non-ketotic coma lacks ketosis and acidosis. There is residual insulin sensitivity and secretion minimizes ketotic response. As there is presence of insulin in small amount or some amount, the ketosis doesn't happen in hyperosmolar coma. Okay, hyperosmolar state may have higher blood sugar levels more than 1000, and elderly population is more vulnerable to that. And HHS often presents later with hyperosmolar symptoms. The hyperosmolar symptoms will be similar to dehydration. They will be drowsy, irritable, agitated, unconscious, the same state. Okay. So with this, I would like to conclude this session, and